Hi everyone and Assalamu alaikum. This is Dr. Jaman Khan and today we are going to discuss management of metastatic breast cancer disease. So the learning outcomes of this presentation will be that we will be learning the management of stage 4 breast cancer. We will also be talking about the radiotherapy and its different types. And we will also be learning that how to decide when to give chemo, when to give hormonal therapy, or when to give trastuzumab or monoclonal antibodies. So what will be the management of stage 4 metastatic breast cancer? We know stage 4 breast cancer means the last stage of breast cancer, in which disease has already spread to different organs and it is no more curable. Yes, letting go is hard, but sometimes holding on is harder. The treatment of metastatic breast cancer is very challenging for healthcare team because it is incurable. Metastases, they have involved many organs, and the patient not only feels symptoms of the disease, but can also feel the symptoms that are treatment related, and that can add up into her misery. So the palliative care is our goal. Our aim is to ameliorate the symptoms of the patient as much as possible and help her to maintain or improve a quality of life. So palliation is the mainstay of treatment that is provided in stage 4 or metastatic breast cancer. And what do we mean by palliation? To palliate a disease means to treat it partially or as far as possible, but with the belief that you won't be able to cure it completely. You ease the severity of pain, but you cannot remove the cause. So this is a case scenario of a patient, a 68 years old lady who has locally advanced breast cancer that is fungated through the skin. She also has liver metastasis, and she has local complications of severe intermittent bleeding from the growth. What treatment you will offer to this patient? Luckily, the growth had fungated through the skin, but it was mobile over the chest wall. So we decided to give a palliative mastectomy, which is also called toilet mastectomy. And what do you do in toilet mastectomy or palliative mastectomy? You go for a mastectomy without going into the axilla. Your aim is just to remove the fungating growth that is causing bleeding, problem to the patient, but you do not do with an intent to cure the patient of the disease because it has already spread to the other organs. You raise the skin flaps, you remove the fungating area. At times, a part of the adherent muscle is also needed to be removed along with the specimen. And after that, you do lavage with the hypertonic saline to destroy spilled cancer cells, and you close the wound. You don't give a try to go into the axilla because there will be fixed lymph nodes engulfing the axillary vessels, and you may cause damage to them. So this is the specimen of a palliative or toilet mastectomy. The whole of the fungating mass has been removed without going into the axilla. And this is the final outcome of surgery. The patient has finally be free from that fungating growth that was causing problem to the patient by bleeding. Yes, we have seen the cases in which the fungating growths, they cause bleeding. At times, patient present with infection in the fungating growth. And if the hygiene is poor, we also have seen maggots inside the fungating growth. So palliative care doesn't mean the palliative mastectomy only. It also means palliative chemotherapy, palliative radiotherapy, palliative hormonal therapy, palliative immunotherapy, or the palliative care for metastasis or any of the patient's symptoms, like painkillers if the patient feels pain. If there is pleural effusion, just intubation may be done. So this all includes in the palliative care. According to the receptor status, estrogen receptors, progesterone receptors, and HER2 new receptors. Patients with breast cancer, they have been divided into different subtypes. HER2 positive and HER2 negative. That comprises of the most common type of the breast cancer cases and account for 73% of the all breast cancer cases. It is associated with the best prognosis. Hormone receptor negative and HR2 negative, it is called triple negative breast cancer disease, accounting for 13% of the all breast cancer cases, and it is associated with the worst prognosis of all. HER2 positive and HER2 positive, that comprises of 10% of all breast cancer cases, while HR negative and HER2 positive accounts for 5% of all the breast cancer cases. So keeping in mind these receptor status. In metastatic breast cancer, you will provide chemotherapy to all the patients, whether they are ER/PR positive, ER/PR negative, HER2 positive, or HER2 negative. If the patient is ER/PR positive, you will go for endocrine therapy. And if the patient is HER2 positive, you also give HER2 targeted therapy. If the patient is a combination of any of these two, you will choose treatment accordingly. But as a rule, chemotherapy is given in nearly all the patients. Radiation therapy or radiotherapy. It is a highly effective way to destroy cancer cells in the breast that may stick around after the surgery. It can reduce the risk of the recurrence by 70%. Radiation therapy is relatively easy to tolerate, and its side effects, they are limited to the treated area. There are different types of radiation therapy. The first one being the external beam radiation. This is the most common type of radiation therapy for women with breast cancer. The radiation is focused from a machine outside the body on the area that is affected by the cancer. The extent of radiation depends on whether mastectomy or breast conservation surgery was done, and whether or not lymph nodes are involved. If mastectomy was done and no lymph nodes had cancer, radiation is targeted at the chest wall and at the places where the drains exit the body. This is how external beam radiation is given. The equipment has an ability to rotate around the patient and irradiate the required area. The other type is internal radiation. Sometimes we also call it partial breast radiation or brachytherapy. Internal radiation typically use small pieces of radioactive seeds which are placed in an area around from where the cancer was removed. These seeds emit radiation into the surrounding tissue. The area that's very close to the site of the original cancer is the area that is at highest risk of recurrence. So brachytherapy provides radiation to that nearby area in order to reduce future risk of recurrence. So here you can see the different brachytherapy seeds, how they look like, and how when they are placed inside the cavity after breast conservation surgery, preferably. Radiotherapy is not without side effects, but they vary from person to person. There could be radiotherapy causing dermatitis. There could be sunburn type skin irritation of the target area. The skin can be red, dry, tender, or itchy. Or breast may feel heavy and firm after radiotherapy. So what are the principles of immunotherapy? Immunotherapy is based on the principles that the body's own immunity should be used or should be augmented to fight the cancer. And how does immunotherapy work? In the case of the cancer cells, tumor cells bind to the T cells and causes their deactivation. So when T cells, they are deactivated by cancer cells, they are no more available to defend the body. So immunotherapy drugs, they act at this level where they can block tumor cells from deactivating T cells. So the summary of this presentation is that management of stage 4 breast cancer is palliation. It could be in the form of palliative mastectomy, chemotherapy, radiotherapy, hormonal and immunotherapy, and treatment of the symptoms. We discussed radiation therapy. Its different types could be internal or external. We discussed that chemotherapy is given in nearly all breast cancer cases. And hormonal therapy is effective only if hormonal receptors are positive. Trastuzumab is given if H2 receptors they're positive. That's all for today. I hope you liked the video. Thank you very much. See you next time.